So the next lecture will be done by Professor Martin Rössle from Freiburg in Germany. He's a professor of medicine with a large expertise in portal hypertension and TIPS. And the lecture is entitled Treatment Algorithm for Portal and Mesenteric Vein Thrombosis in Cirrhosis. Please.
Chairman, ladies and gentlemen, before I start with talking about treatment of portal vein thrombosis, I would like to give you some introducing remarks and some statements on the pathogenesis of portal vein thrombosis. First, portal vein thrombosis is frequent in patients with cirrhosis, amounting to about 10 to 25% in this group of patients. Second, portal vein thrombosis increases mortality after liver transplantation, which can go up to 50% within 1 year after the transplantation. And third, stasis is the main reason for portal vein thrombosis. It could be shown that a maximal flow velocity of less than 15 centimeters per second in the portal vein is a risk factor for portal vein thrombosis. And TIPS restores the flow velocity in the portal vein, and therefore it prevents portal vein thrombosis very effectively. Fourth, microembolization into intrahepatic branches may precede visible extrahepatic portal vein thrombosis. I will come to this point later. Now, let me explain why stasis is so important in the genesis of portal vein thrombosis. This is a profile of the flow velocities in a normal portal vein. And you can see in the center of the portal vein, you will find a maximum flow velocity of about 40 centimeters per second in a normal candidate. And when you move towards the wall of the portal vein, the flow velocity of the particles decreases very rapidly, and at the border of the portal vein, you will have a flow velocity which is close to zero. And this is also demonstrated here in this Doppler sonographic photograph. You can see here the portal vein with the Doppler probe here, and you see the Doppler probe covers the whole width of the portal vein. And here is the flow velocity profile, and you see there are some particles which do not move at all, which have a flow velocity which is close to zero. This is the zero line. And you have other particles which move very rapidly with a flow velocity of up to 50 centimeters per second in the portal vein. And the particles moving at the border of the portal vein, they do not move really, they do just roll, and they have a very, very low portal vein flow, a very, very low flow velocity, and the particles in the center of the portal vein, they have a very high flow velocity. And what happens with the cirrhosis? We have a reduced maximal flow velocity by about half of the normal value, and this causes that the traction forces on the particles at the wall of the portal vein are also very much reduced, and these particles may come to stop, may not move anymore, and this is the beginning of the portal vein thrombosis in cirrhotic patients. Now, this is an example of a patient with ascites who have got a TIPS. Before the treatment, nobody told us that the patient may have a portal vein thrombosis because nobody saw the portal vein thrombosis with imaging procedures. And I would like to ask you, where is the thrombosis? Do you see the thrombosis? I will tell you there is no answer. I will tell you the thrombosis is at the whole length of the portal vein, going from here to this location, to this place. And you see here some irregularities within the portal vein and the confluence, and here also. And the width, the diameter of the portal vein is only 5 to 6 millimeter, and there is no other reasons available that justifies such a small diameter of the portal vein. So the thrombosis develops as a lining of the portal vein, and therefore I would like to call that lining thrombosis, and the center remains patent. Why does it remain patent? Because with narrowing of the vessel, the flow velocity in the center increases, and therefore this remains patent for a longer time, and it can be like this for a very long time. But this patient has an additional thrombosis or occlusion or embolization, and I think you may not see it, but I tell you, this is the left branch of the portal vein, and this is the right branch of the portal vein. And you see here the secondary branches of the portal system here and here, left and right. But there are no secondary branches going to the right liver lobe to the segments 5 and 6. And this is probably caused by microembolization at the time of formation of the thrombosis in the main stem of the portal vein. So this is exactly what I told you before with the stasis. It causes thrombosis, a lining thrombosis, as long as the portal vein flow velocity is low, and with increasing thrombosis, the portal vein flow velocity also increases and prevents further growth of the thrombus. The patient has then got these tips. You see here it's a covered stent with a diameter of 7 to 8 millimeters, and you can imagine that the portal vein here is not 7 millimeters, it's not 6 millimeters, it's very small. And when you follow these patients after 4 months, you can in many patients realize that the thrombosis is resolved to a great part, and the shape of the portal vein is in some patients like normal. I would show you another case, and I told you the stasis is the main factor, but there are some exceptions, and this patient is an exception. As you can see here, we injected contrast, and you see here the blood flow coming from the superior mesenteric vein is divided into 2 parts. The one part is going here into the liver. This is the regular situation, and you see here the branches at the right side of the liver, which you did not see in the patient before. And another part is going in this direction, retrograde into the splenic vein and the inferior mesenteric vein. That is completely wrong. That should empty in this direction, not in the wrong direction. And they fill varices and so on. So you have a kind of watershed at this situation here, and the watershed always produces some turbulent flows, and this may be a reason why the patient has a high risk of portal vein thrombosis at the location of the watershed. And this is independent of the stasis. That is a completely different mechanism, but it may be also important for to get a portal vein thrombosis. So after this few introductory remarks, I will come to my presentation on treatment of portal vein thrombosis. There are 3 levels of treatment. The first is the prophylactic anticoagulation before thrombosis occurs. The second is the therapeutic anticoagulation. Thrombosis is present. And the third level is the transjugular intervention of a thrombosis, probably together with a local thrombolytic treatment. And after having discussed these points, I would like to give you my suggestions on the treatment algorithm of portal vein thrombosis in patients with cirrhosis. First, the prophylactic anticoagulation. None of these patients had a portal vein thrombosis, but they received enoxaparin. And this trial, the only one with this approach, was published in 2012. It was a randomized trial including 70 patients with a child Buick score of 7 to 10. Varices grade 3 were excluded from the study. I think this is important. And the patient received a prophylactic dose of enoxaparin during 48 weeks of follow-up. And here you can see the results. These patients had no enoxaparin, and many of these patients developed a portal vein thrombosis during 1 or even 2 years of follow-up, close to 40% of these patients. And the patients receiving enoxaparin did not develop the thrombosis. The enoxaparin was stopped here. But the second year, they did also not develop thrombosis. Only 3 years thereafter, after start of treatment, they start to develop portal vein thrombosis. What's about decompression of the portal hypertension, decompensation of the portal hypertension? Here is the probability. You see much more patients without enoxaparin decompensated with ascites and variceal bleeding, and even the survival was much better in patients who've got the treatment. So this is a landmark paper, I think. It's unfortunately the only one we have, so I think at the time present we cannot recommend the treatment, but in patients with a high risk of portal vein thrombosis, we may make an exclusion. Second, the therapeutic anticoagulation. There are 5 studies available, and you can see here the number of patients included. The studies are very small. The studies are retrospective studies beside the study by Solo, which is a prospective study, and patients have got low molecular weight heparin, followed by vitamin K antagonists, and in 3 studies, vitamin K antagonists were given, and in this prospective study, only low molecular weight heparin was administered. These are the results. You see here the complete response, complete resolution of the thrombosis in about 40% of patients. This is the prospective study, which I think is the most important one. And in this study, 64% of patients did not respond. They had no resolution of the thrombosis. There are some questions remaining, and I would like to ask these questions. There may be some more, but these are, I think, the most important ones. Which drug should be given? I would prefer low molecular weight heparin because of the risk of bleeding, using vitamin K antagonists in a prophylactic dosage that cannot be very harmful for the patient. When to stop anticoagulation? Never when it's effective, because it could be shown that if you stop anticoagulation, you will get a thrombosis. That is the same in the therapeutic setting as in the prophylactic setting. Do we need thrombophilic testing before treatment? I believe no, it does not play a role in the great majority of patients. Are there contraindications? Yes, maybe, we don't know exactly, but high-grade varices and platelets below 50,000 may be contraindications. We need more information. Now, what's about the transjugular intervention using TIPS and thrombolytic treatment? I show you the technical steps. First, you puncture the usually right branch of the portal vein. Then you implant a stent, because without having an outflow in these patients, the resolution of the thrombosis will difficult or not possible. Then you can introduce a sheath and aspirate some thrombotic material for diagnostic reasons. You can perform a fragmentation, a mechanical fragmentation of the thrombus, and you can embolize varices if varices are present to have a higher, to be sure that no bleeding occurs when you perform a thrombolytic treatment, which is the last step in this setting. Now, there are a few studies available with very, very low numbers of patients, but there is one study. This is also a mild step published by Luca in 2010, and this study included 52 chronic portal vein thrombosis patients with cirrhosis and 18 recent patients. They implanted a TIPS, but they did not give any additional anticoagulation. And this is the situation before the TIPS implantation, and this scale shows you the percentage of occlusion of the portal vein. You see here below 25, below 50, below 75, and below 100% occlusion of the portal vein. You see this group of patients, 55%, have an advanced portal vein thrombosis, and these patients may have a mild portal vein thrombosis. What happens after the TIPS procedure? 57% of the patients get rid of any thrombotic material in the portal vein without anticoagulation or thrombolytic treatment. And 0% of patients had a severe thrombosis at the end. And only few patients had some kind of thrombosis that was clinically, in most of the cases, not relevant. So this is a very good result for the TIPS procedure, even in patients with a chronic and older portal vein thrombosis. Now I would like to summarize. Looking for stasis, lining thrombosis, watershed flow, and microembolization should be part of the diagnostic array in patients with advanced cirrhosis. Second, prophylactic anticoagulation may prevent thrombosis, reduces decompensation, and prolongs survival, but unfortunately we have only one study available. And third, therapeutic anticoagulation has a limited response of about 40%. Fourth, TIPS is very effective in the prophylactic and therapeutic setting of portal vein thrombosis. Finally, I would like to give you this own suggestion of a treatment algorithm. You have a patient with cirrhosis with a risk of portal vein thrombosis. You can give, if the risk is very high in your eyes, you can give this patient a prophylactic dose of low molecular weight heparin. And if there is a obvious portal vein thrombosis, we can divide the patients in symptomatic patients with portal hypertension, with variceal bleeding or ascites or something else. And I would suggest to give these patients an early TIPS to prevent further symptoms, to improve the symptoms, and to treat the portal vein thrombosis. And this can be combined with a local thrombolytic treatment. We perform a 3-day urokinase treatment, which resolves the thrombosis in most of the patients. Then we have the asymptomatic portal hypertension. The patient has no complaints from his portal hypertension, but we see a portal vein thrombosis and the patient has a cirrhosis. If this thrombosis is limited, non-occlusive, very fresh, low molecular weight or vitamin K antagonists can be given because they may have a good result and a good response. If there is no success, the patient can have a TIPS. If the thrombosis is complete, very extended, chronic, and there are varices at risk of bleeding, or the patient is an LTX candidate, I would prefer the TIPS implantation because this treatment is not very effective in these patients, and an LTX candidate must have a patent portal vein, otherwise he has a high risk of dying after the liver transplantation. You may not have to implant wide tips, because in this group of patients, we do not look at the pressure reduction. The patient is asymptomatic, but we would only like to have acceleration of the portal vein flow velocity to prevent further thrombosis and to recure this thrombosis, which was the reason for the TIPS implantation. So this is the last slide, and I thank you very much for your attendance.
Thank you very much, Dr. Rössle. I think very important and again relevant topic. My first question is there any role for the new oral anticoagulants in the prevention or treatment of portal vein thrombosis?
Yes, I believe so. I would like to give the patient 10 milligrams of Xarelto.
Mm-hmm.
That would be maybe a compromise and would be much more digestible for the patient and acceptable for the patient.
Do you have experience already?
There are no studies around now with that kind of treatment.
In general, we treat a patient, not a vein, right? So the question for me is, what is the indication to do that? Because many of our patients with portal vein thrombosis and cirrhosis have HCC, are older, have decompensated cirrhosis. So has it really been shown that opening up the portal vein would improve their prognosis?
I had a problem of understanding.
So the question is, it's nice to open up the portal vein, but I don't think that will improve the prognosis of many of these patients.
Oh, yes.
If it is a bridge to transplant, yes. If they have a relatively preserved liver function, probably yes. But in patients with decompensated cirrhosis or with HCC, probably not.
If the cirrhosis is decompensated with respect to the portal hypertension, there is any reason to implant the tips. If you mean a functional decompensation or the patient has a hepatic encephalopathy, you will not improve the patient with the TIPS implantation, but you bring the patient in a better position for a liver transplantation.
Has there been any studies done that this would improve survival overall?
Yes, there are studies. I showed you the prospective, the randomized prophylactic study, which showed very nicely the improvement of survival. And there is another study with medication for therapeutic anticoagulation by Delgado, which also showed an advantage with respect to child glass and survival.
Last question, Stefan Seutzer.
I'm sure that in our clinics we are not taking attention on these problems sufficiently. So I actually need to ask you 3 questions. If stasis is so important, what is then the role if I give to the patient a non-selective beta blocker to further lower the splanchnic pressure? Is that increasing the risk of lining thrombosis? Number 1. Number 2, with the NOAAs, Heiner Wedemeyer just mentioned, is there any pharmacokinetic understanding which of the 3 approved NOAAs have the best pharmacokinetic property in somebody who has liver cirrhosis? And the third question is, if you open your thrombosis with the TIPS, you mentioned that no anticoagulation is given, and the question would be, any experience to get those patients, once you have a covered TIPS inserted, put on a low molecular weight heparin or not?
So you have 20 seconds for each answer.
Yeah, the first question, I think after beta blockade, the risk of portal vein thrombosis may increase. In any case, you reduce the portal vein flow, you increase the risk of thrombosis, but it may not be well investigated. And if you, for example, perform a splenic artery embolization, which also reduces the blood flow from the splenic vein, you have a really considerable risk of portal vein thrombosis. And if you do that in a cirrhotic patient, you have to put the patient on anticoagulation. So I think with the beta blocker, the effect of the beta blocker is so minimal that you may need 5,000 patients to show that the portal vein thrombosis is increased. You decrease the portal vein pressure with a beta blocker by about 1 to 2 millimeters of mercury. That's close to nothing. Okay. And your second question, I cannot answer the question. I have to first to study the different metabolisms of these medications. We did not have performed a study like this in the past, but we may do that in the near future. Okay. And your third question was why using anticoagulation after TIPS? I don't think it's necessary. If there is an extended thrombosis in the beginning, when you implant the tips, I would perform some short thrombolytic treatment because you have a much faster response. And after 3 days, most of the patients had a completely patent system. And this makes fun, and this is good for the patient and for yourself. So this is my recommendation, but no further thrombolytic treatment, okay. No further anticoagulation.
Okay. Thank you very much. We've been pushed here by the emails to continue, to keep this time on time.